So in our second year of med school, so I'm in my third year now, we are assigned a community organisation, and they can range from charities. So myself and the other students in the room were assigned to 15 Square, and basically you do with that what you will. So you're assigned this charity and you get given 7-8 months to interact as much as you want to with them. And I think David and the team, Jason, facilitate that really well with the students. And as he said, we get the opportunity to delve into an area we find of interest to us. So I was here last year virtually watching Shirin's presentation where she, like David said, rips the BMA to shreds. And I sort of touched on that again ever so slightly in this, but so I chose to go down the route about clinical resources. So in your second year of med school, you're taught where to go if you've got a question related to something medical, whether that be you're not sure how, if a patient came to you with X, Y, Z condition, what do we do? And that's where this idea came up. I thought, okay, because this time last year I was in a position which probably all other 160 people in my cohort at med school are in, where they actually had no idea. So there's 4 med students in the room now, that's great, but there's also another 300 at the med school that have probably never even heard of something like this. This is the most teaching I've had I'm now at the halfway point, I'm halfway through my medical school years, and this is the only teaching I've had, which is concerning, but also makes the 4 of us in the room incredibly fortunate to know these sorts of things. So I done, which probably a lot of med students do, which is sometimes frowned upon, went straight to ChatGPT when I joined this organisation. I thought, right, okay, let's start from the very beginning. What am I getting myself into? What is this place all about? This is what ChatGPT gave me. So I asked it to specify the difference between therapeutic and non-therapeutic male circumcision. Therapeutically, it gave me the answer that's on the screen here, so I'll read it out. So it's performed for medical reasons to treat or prevent a specific health condition, such as phimosis, paraphimosis, recurrent infections, other abnormalities, and it's conducted as a medically necessary procedure, usually recommended by a healthcare professional. So that falls under the therapeutic branch of male circumcision. You've then got the other branch, which is the non-therapeutic area. So obviously performed for non-medical reasons, whether that be religious or cultural practices, personal or parental preference, which I think is very key, aesthetic reasons, and also just to note that it's typically elective and not necessarily driven by a medical need. I've highlighted those 3 points, so phimosis, paraphimosis and recurrent infections. They've all been cured by non-surgical interventions. And normally the go-to with any medical practice that we get taught is you opt for the least invasive procedure possible. If someone needs antibiotics, you don't go straight away and shove a needle in their arm to give it to them. You'll often go by the mouth because it's easier and less invasive. So why is it when you get involved with something that is a little bit more niche, for want of a better phrase, do they go straight to this deep delve into quite an invasive procedure? And one of my colleagues who I was on placement with last year touched on this in his presentation. So he went through a whole host of conditions related to the male genitalia, and he came up with these conditions and showed all the many ways in which they could be treated. Exploring the impact of clinical resources. So this is the NICE guidance. So as a practicing clinician and training clinician, we go to NICE guidance for almost everything. You type in anything related to male genitalia and absolutely nothing comes up. Similarly with, there's some other guidelines there. This is directed towards nurses, midwives and allied health. Even so, if you read that document, it doesn't really give you anything. And then also, this was the very small branch, I can't remember exactly which document this come from, but it's basically just saying that it's they need to have a discussion about it. So it leaves myself, medical colleagues, in a bit of a position where we have to sort of use our own initiative, and on an area which is so sensitive, an area which is so sort of seemingly understudied, it leaves us in quite a difficult position. This was delivered to my colleagues who also came on placement, so I tried to introduce the idea of the reasons that people are circumcised. So this is for non-therapeutic reasons. Religious reasons that this happens, so it's common practice in Judaism, and also looking towards the states as well. Sometimes it can be deemed a bit of a social norm to have this sort of procedure done. And interestingly, it was described by one place to be a preventative measure for an array of pathologies, which is quite an interesting statement. So yeah, this just again touches on the reasons and why they occur, how they occur. So if we go onto the standard Jewish practice where circumcision occurs, it's often undertaken by someone associated with the reason. So whether that be someone within the faith, for example. So in Judaism, it's undertaken by Mohel, a Jew trained in circumcision. I use trained quite lightly because these people are trained in undertaking this procedure for a religious reason, whereas they're not trained in things such as human anatomy, aseptic techniques, so ensuring there's no infections following on from the procedure, and also things that can go wrong. So sometimes we're taught that these procedures are great and they work, but sometimes these things can go very wrong, and that is not standalone for a procedure just like this. So this goes back to what we were doing. So we've had someone come into us, we've got no resources, so what do we do then? This required me to do a lot of digging just to get those 3 resources, which gave me absolutely nothing. And medical school teaching is completely limited, and some would even say completely non-existent. So I'm 50% of the way through my medical degree now, and I've not even heard the word circumcision come up. So in our first year of study, we touch on the male and female anatomy. So we look into what you'd expect as a basic level of anatomical knowledge, and importantly, we cover things like female genital mutilation and safeguarding concerns and practices there. But interestingly, nothing comes up with regards to male genitals. So I thought, okay, let's have a little bit of a look and let's think very simple. So for the people who are non-medical in the room, I'm sure a lot of you have seen this poster here. So this is related to sepsis, so nothing to do with male genitals. But you see these things plastered in the GP practices. A lot of ambulances have got things for spotting the signs of sepsis. And I'm sure if I went around the room, a few people would be able to pick up on a few of the signs to look out for when you look out for sepsis. So this resource is probably a very simple way for clinicians to, if they have someone come in, to really quickly pick up on this, because it's quite a dangerous presentation to come into any form of healthcare organisation with. And importantly, it's a great way to avoid massive complications which can occur, and it's very simple. So that's where I worked with 15 Square over the past sort of 8 months, I would say. And we thought, okay, if there's a resource out there for something very common like sepsis, why is there not something out there for things like male circumcision? So we come up with this. It's about an 8-page document or so, and it basically gives guidance to myself, practitioners in the field who perhaps haven't come across this yet, or perhaps have and just don't actually know what to do. So this is, I mean, it's a little bit difficult to see on the screen here, but this is basically follows the very simple sort of rhetoric that the sepsis chart went through. And it gives you a flow chart, because a lot of people learn quite well with flow charts, especially in medical school when you're a little bit puzzled with a decision. So it basically poses the question to a clinician when you've got somebody coming in with some issue related to specifically the foreskin on a male, whether that be child or an adult coming themselves. And basically, as you follow down the branches, it just enables clinicians to really quickly pick up on things that are very normal. So for example, on the yes branch on the left-hand side, okay, someone's presented with a foreskin abnormality, and this asks straight away, is it pediatric normal non-retractability? So when you've got a youngster that comes in, sometimes they may have an issue related to their foreskin, which can be actually very normal and something that disappears with age. And basically this tells you this is normal. We don't need to intervene. For goodness sake, we don't need to perform circumcision at this point. But also it then goes down the branch of, okay, maybe it's not, maybe it's an adult, but we've got conditions that can be managed in a much more easier way, much less invasive. So you've got phimosis, paraphimosis. But importantly, what this does as well is it doesn't rule out the need for circumcision, because often there can be cases where in medical emergencies, these things are necessary, which is understandably difficult. And I think that's where the awareness of myself and colleagues as well, to know how these things work and know that these things actually can be quite significant as well. But also, and then on the other branch of it here, the no aspect. So why have they got an issue? No, they don't. What is the reason for them coming in? Is it religious? Is it just sort of a social norm like I described earlier? So this looks into the risks and the harms which could follow. This article here is something that I was pointed to by Jason and David in the team when I was on placement with them. And it basically suggests that if this procedure is done and it goes wrong, it can be very, very bad. Non-medical practitioners, like I was describing earlier, if it's done for a religious reason, can lead to functional, aesthetic complications and also significant psychological harm as well. And this can result from lots of things, whether that be lack of medical expertise, complications from a surgery. This article here specifically points out how it was done using tools which had perhaps never been cleaned down an alleyway. And if this was any other procedure, I'm sure it would be much more headlined on the news if things like this were happening. I'm sure everyone in the room is no stranger to Alex's story. So this was a book that was handed to me by David when I first came on placement. And I read the whole thing for this presentation. This is a chap who unfortunately committed suicide as a result of his circumcision. And importantly, it points towards one of the massive points that 15 Square are such a big advocate for, and that's supporting people after the procedure. Even if it does have to happen, the support that people need afterwards is absolutely crucial. This was an interesting thing, which a lot of people were quite confused when I first posed the idea of satisfaction of a procedure. If we looked at circumcision on its own, you might think, okay, satisfaction's a bit difficult. So David and the team described it to me as it's a functional part of your anatomy that you're removing when you have a procedure like this done. So I thought, okay, let's go for something perhaps at the other end of the scale, and this follows people who had amputation of the upper limb, anywhere from the shoulder downwards removal. And the people who had this looked into those, and it suggested that 64% of those people were satisfied post-procedure. Looking into circumcision puts those satisfied at 66.2%. So it puts people almost on par who have had the removal of their entire limb, whether that's one or both, on those with male circumcision. So it's completely, this sort of statistic threw me back slightly, because you would think, how can perhaps such what we are taught to be quite a small part of human anatomy cause such reduced satisfaction? So 66.2% might seem quite a high number to be satisfied, but that's leaving 35–40% of people completely unsatisfied with a medical procedure that they've had done, and sometimes for completely unnecessary reasons. So this was then looking into, okay, if we did have these access to more clinical resources, could it actually be beneficial? And the simple answer is we don't know, because they're not there. It's hard to prospectively try and put something out there to think, okay, if we've got this available, will it change things? This is just an array of studies here that I presented to my colleagues, trying to illustrate how there's complete confusion across the world with procedures like this. So the top one there looked into the prevalence of circumcision, how it's changing. The middle one there, interestingly, from Dr. Brian Morris, who we've had many chats about when I came to the office, suggests that declining levels in Australia was actually changing attitudes towards medical necessity. So that potentially is a step in the right direction. But then on the bottom, on the contrary, perhaps, that in many European non-religious countries, it's almost unheard of. Interesting things available to us, and this was all on a medical journal's website. So this is about all we've got as medical professionals. So it really confuses people in the field. So this links back to the sepsis diagram. So when this poster was introduced by the UK Sepsis Trust, there was a significant improvement in the management of sepsis. It was updated in trust-wide protocols that they needed these things in place. So one of the big things is sepsis 6 for management. And ultimately the result of this is people were in hospital less, and there was also a decrease in mortality and morbidities. So basically what this is trying to show is, if there is a clear resource available to clinicians, it does work. So policy, promoting safer practice, again, looking back at the sepsis guidelines, this is in the US, so not in the UK, but so mortality was lowered by 10% when these proper guidelines were put in place. There was high compliance in hospitals, so people were actually following these things. It's great having these guidelines put out there, but if no one's going to follow them, it's pointless. But there was high compliance, so these are all good things that suggest if the clinical resources are there, they do get used. So I told you I would bring up Shirin's point from last year on the BMA. Interestingly, this is like gold, this image now, because you can't actually find that anywhere on the internet. And I found that out halfway through doing this presentation with the guys at 15 Square, that actually this had been completely wiped. And if this was the only resource available to us, it's now gone. So there's absolutely nothing. And there's limited teaching in med school, and now a year on from doing this presentation, I'd actually say it's completely non-existent teaching in med school. The BMI guidance is rightfully so being disputed. There's not a lot of evidence, and unawareness of clinicians, and which results from the lack of teaching. So if I was to go back to my medical school today and go and see the other approximately 160 people in my year and ask them about this, most of them would have no idea. And by most of them, I probably mean every single one of them. No one's really heard of a non-therapeutic versus therapeutic. No one would know what to do if anyone even came to them. So what can we actually do? This is great, us promoting things, but I remember back in my interview for medical school, I was asked, where do we think that the most of promoting health comes from? What I said in response to that was a lot of it comes from these higher political powers. It's great us standing here today and talking about this, but ultimately, if you've got someone at the top that's telling you the wrong thing, it's going to push things very much in the right direction. So to discuss this image a little bit, that's Robert F. Kennedy there. And he actually spoke about avoiding circumcision, but interestingly, he spoke about avoiding it for the use, so then we can avoid paracetamol use for the potential links with autism. So that's something immediately, so there's all these good things in place, but then you've got somebody at the top who decides to associate a very common drug with quite a severe condition. So it leaves us in quite a difficult position. So this is basically a very simplified diagram as to how we can make things better. So you've got a patient that comes in requesting a medical procedure. At the minute, people are confused. We don't know what to do. If we train people better at this level, so you get early exposure in medical school, that's great. You've got people that at least know what's coming through their door. The patients better understand their procedure. It's often understood that if patients understand their procedures, it creates such a better bond to work with your patients as doctors. And the guidelines, if and when any guidelines ever show up for us, can these be used to appropriately manage these patients who walk through the door of a GP practice or come into hospital? And importantly, the end result for this being the best clinically appropriate outcome for the patient. And it was made clear from the guys at 15 Square when I first started, they're not opposed to these things if they're medically necessary. Because ultimately we're taught from the very beginning that we have to do the best clinically appropriate thing for our patients. And with the right tools in place, can the best clinically appropriate outcome be made for all these patients? And I believe that is all I've got to say, but thank you very much.